So this is her x-ray. Before you proceed, always make sure that your position is good enough to take a good x-ray. So what is the ideal position? In terms of ideal position, you want to be aiming for anteromedial aspect of the humeral head. So this is the superior part, this is the medial part, this is the anteromedial part. So this is where we want to aim, and this should be in line with the coracoid process. So we are aiming for roughly this part of the head. If you are here, you are too lateral. If you are here, you are too medial, you will be hitting the glenoid. You just want to be here. So this is where we want to enter in line of the glenoid. Perhaps here would be perfect. Now, hydrodilatation is an extremely useful procedure. It is good in relieving pain in around 90% and improving range of motion around up to 70% of the patient. Now, the equipment that we will be needing is this is the artery clip just to localize our perfect entry point. Then we'll need a spinal needle. This is used to do hydrodilatation. This is size 22, as well as giving local through the tract so that the patient doesn't feel pain. This is some local anesthetic. This is our omnipaque dye. This is depomedrone. I give 80 milligrams with some 1% lignocaine. These are 20 ml of saline to do the hydrodilatation. This is the connector, which is extremely useful when you do that, and I'll explain everything again as I go through the procedure. So first step is to localize your ideal entry point. So I've just used a mosquito and taken a C-arm view, and this looks at the position of where we should enter our needle to do our hydrodilatation. So if you look at the C-arm images, this is our ideal entry point. So this is the anteromedial aspect of the head, and it is in line with the coracoid process. So I've marked my entry point, so I'm just going to give some local anesthetic. This is to anesthetize the skin. So next step will be just to use the spinal needle and just go slowly and infiltrate the whole tract so that patient doesn't feel pain when we are doing the procedure. So third step will be to choose the same entry point and go vertically till you hit the humeral head. So I just felt a giveaway. I'm just going to confirm the position whether I am in the shoulder joint or not. So looking at the position of the needle, it looks pretty good to me. It is at the anteromedial aspect of the humeral head, and it's also in line with the coracoid. I just need to confirm this position with injection of around a ml of omnipaque, and if it is correct, then we will proceed with hydrodilatation. So I'm just going to inject a bit of omnipaque. Make sure that once you feel that you are in the right spot, protect this needle like your life so that it doesn't go in and out. Otherwise, it's very easy to come out of the joint. So this is our picture, and this is how the arthrogram of the shoulder should look. It is nicely following the contour of the humeral head. This is some dye going on to the inferior recess. The normal amount of fluid that a joint can accommodate is around 8 to 15 ml. However, this is reduced dramatically in frozen shoulder, and certain studies have shown that shoulder can accommodate only up to around 7 ml. So you can see I have just given 1 ml of dye, and even that is flowing out. That means that is also an indirect giveaway that you are at the right spot. If your fluid is or dye is going in a free space, it's not going to come out. Now see, I have just injected 1 ml. The space is so tight that even this 1 ml is trying to come out. So next step what I do is I try to inject the dye out as much as possible. It's not always possible, but it's a good practice, especially in small joints. You want to give maximum amount of fluid. The shoulder joint is a reasonably big joint, so I don't think I will be able to extract much, but always try to take some dye out if you can. I think this is one most important equipment that you need for hydrodilatation. For hydrodilatation, you want to make sure that your needle doesn't move. So all you need is to connect this to your spinal needle, making sure that you don't move it. And what it does is, now you are free to inject the fluid without endangering that this is going to move. If you don't have access to this, then you can ask your assistant to hold it and you inject, or you can hold it or your assistant can inject. So this is around 80 mils of depomedron, which is gone with 1% lignocaine, and you will see how much force you require. And I'm just trying to do it, and I'm trying my level hard. This is the time when patient do feel some discomfort because of the pressure. So I'm just trying to insert, and I'm finding lots and lots of resistance. This is normal. That means you are in the right place. If you are outside the joint, this will flow freely. And what happens is, once the joint capsule has ruptured, then you will feel that it's going with ease. So we have injected 10 mils of local anesthetic with steroid. I have not found that giveaway, which is suggestive of rupture of the capsule. One controversy is how much fluid shall we give in order to do the hydrodilatation. So I would recommend give at least 30 to 40 mils in order to do the hydrodilatation. If you find the sensation of giveaway, that the capsule has ruptured, that means that is enough fluid that you have put in, and you can stop at that stage. So I'm just going to inject, and I'm still finding a lot of resistance. And I'm requiring to use a lot of force. So you need really strong pair of hands, especially if it's tight, and at one point you will find that this will give away. So you can see that I'm injecting and it's backing out. It means still the capsule is not ruptured. So that's much better. It's getting there. That's it. Now can you see that it's gone much easily. So that is suggestive that the capsule has ruptured. Now